Okay, let us discuss about ischemic heart disease as one of the conditions which affect the heart in this series of cardiovascular diseases. So, let us look at the introduction of this ischemic heart disease. So, ischemic heart disease in some literature, it is also called the coronary artery disease, or sometimes it is called coronary heart disease. So, this disease results from a dysfunctioning of myocardial cells of the heart, resulting from insufficient supply of blood due to either occlusion of the coronary arteries by either a cholesterol or anything which any particle which can obstruct the blood supply to the coronary arteries, resulting to insufficient blood supply. And this one results to the myocardium cells resulting to shifting to anaerobic metabolism, which can result to either lactic acidosis and then destruction of the myocardial cells. This is because there is impaired blood supply, there is an impaired oxygen supply to these myocardial cells. So the causes of many is atherosclerosis of the coronary arteries. This is the handling of the coronary arteries, and it may include either a stable angina or unstable angina, or may include myocardial infarction or heart failure, or sometimes also arrhythmias. Also, sometimes it may be associated with the other conditions like cardiomyopathies can also be associated with the cardiomyopathies as a cause. So let us look at atherosclerosis. Atherosclerosis is when there is a hardening of the blood vessels and can affect any blood vessels in the heart, in the brain, in the limbs, any part of the body, even the extremities of the body, either the upper arms or the lower arms can get atherosclerosis. Either the blood vessels of the eyes, micro blood vessels can get these atherosclerosis, resulting to hardening of these blood vessels. Which can impair the distal supply of blood supply of that blood supply to that organ, resulting to problems. So in the heart, myocardial infection can cause a sudden death. In the brain, it is associated with transient ischemic attack, and then in the lower limbs, it can cause what we call conditional and critical limb ischemia diseases. What it can cause peripheral vascular diseases can all cause what is called peripheral vascular diseases. That means there is impaired the supply to the distal, to the extremities, either of the most commonly the lower limbs because of this obstruction. So atherosclerosis also can affect the turbulent blood flow in the blood vessels, resulting to the plasma cells or any other cells like polymononucleocytes or monocytes attacking the endothelial cells, resulting to intrinsic pathways, activation of the intrinsic pathways of inflammation, or also can also activate the intrinsic pathway of coagulation. So atherosclerosis is a progressive inflammatory disorder of the arterial walls characterized by a phospholipid deposit of atheroma. So it remains asymptomatic for a quite period of time, depending on the state or the how the blood supply, whether they are the organ or the structure of the body affected as other blood supplies, or the extent at which this occlusion has been gone to that extent. So also it can be because of oscillations and distraction of the relations resulting in lumbar obstruction and the distal embolization of the heart of the vessels. And also the coping capacity of that structure of the organ is also very important, because of some organ can compensate by doing what is called a neovascularization. So clinical manifestation depends upon the site of the lesions and the vulnerability of the organ supplied by the occlusion, this occluded blood vessel. So let us look at early atherosclerosis. So the early atherosclerosis happens in the second and the third decades of life, and it tends to occur at the site of altered arterial stress, just as bifurcations, where there is a stenosis, where there is a blood vessel which has been in distractions, like places where also there is an aneurysm of our blood vessels. That is where there is these issues of early atherosclerosis. So it starts with an abnormal endothelial function. There is an abnormal endothelial functions where the endothelial cells now start initiating intrinsic inflammation slowly, because there is no proper turbulent blood flow in that blood vessel. So the cells of the blood start touching the endotheliums, which can activate either endothelin, can activate prostaglandins, can activate and also heparins, and also other mediators of inflammation like interleukin 1, interleukin 6, interleukin 8, and also tumor necrotic factor, tumor growth factor, and also interferon gamma, which are the primary and the first cytokines to cause inflammation. This one result in deposition in that blood vessels, resulting to obstruction and hardening. Also, the fibrin can start getting deposited from the inner part of it, and this is causing a problem. So this result to migration in the intima, and then the intima, the remnant of the blood vessels becoming narrow, compromising the blood flow in it. So take up of oxidized low density lipoproteins particles are taken to deposit there, and you know that low density lipids particles are the one which are burned in our body. So the part there is a deposition of lipid by macrophages or foam cells, and sperm cells dies the lipid poor intimal space with the cytokines and growth factors. So in this, there is a response. Smooth muscle cells migrate from the media of the arterial walls into the intima. So this is the process of whatever you have been discussing. You can see the superficial endothelial cells, the endothelium and the nurture, and then endothelium, you can see the perico, which has inside the blood. This one is not touching the lumen, so but it's causing pressure and causing a narrowing of the blood the blood vessel. There is fibrous tissues which are getting deposited there. There is thrombus, and this thrombus can dislodge and can migrate to any part of the body, either the brain causing stroke, to the heart causing a problem in breathing, and also to the kidneys, to the lungs, or part of the body, and also into the calf muscles, causing what is called deep venous thrombosis. So let us see the progression of ischemic heart disease with the time, and the consequences of progressions, and how does this one grow. So in type 1, there is the intimal lesion. The reason is in the intimal isolation by macrophages and the foam cells. So macrophages and the foam cells. Then it progresses. This is one we can see that is in this patient, they are clinically silent, and it forms from the first decade. So there is type 2, where there is some fatty lesions, streaks, mainly intracellular lipid accumulations into the cells. These ones in the second stage, and it grows mainly by lipid accumulations, and it can happen from first decade to the third decade, and it can either be clinically or subclinically in some patients, depending on the blood supply to the distal aspect, and also the coping capacity of the organ affected. So number 3 is the intermediate lesion, and this one is the type 1 change and small extracellular lipids. There is some deposition inside there, resulting to more women becoming uprooted. There is a deposition there, and also this one also grows in the first and second than decade of life sometimes can be clinically silent or can be clinically have some symptoms. So also we have stage 4, which is called adenoma lesions. This one there is in the position of adenoma inside there, and then this one can also be either clinically or can also be having some symptoms. It also happens from first decade to the third decades, and also we have a number 5, where there is the fibroma, there is fibrous tissues now have started becoming deposited because of the healing processing. The fibrous tissues have started getting deposited here with the lipid growth, and fibrous tissues are made by there is calcifications, and you know very well that lipid and calcium are the one which forms these adenoma. So there is a deposition. This one forms all the from for the decade and for the decade of life. It has clinical symptoms at this point, and it is accelerated by muscle, smooth muscles and collagen inhibitions at this point. So we have point number 6. This is stage number 6. It is complicated, and the key here, there is an embolus. There is a thrombi forming, and this thrombi can dislodge and go to any part of the body. And this one forms from what? From the, for the decade of life. And obviously, it is symptomatic. So let us look at what is called advanced atherosclerosis, because we have just seen the primary atherosclerosis, or what is called early atherosclerosis. So, in an established atherosclerotic plague, macrophages mediated inflammation and the smooth muscle cells promote repair. So the repair is taking place, and this one results to the position of these fibrous tissues. So the cytokines released by macrophages start degrading smooth muscles area of a plague. So now the lesions remains vulnerable to mechanical stress that automatically causes erosion, fissuring, or rupture of the plague surfaces. So any breach in the integrity of the plague will expose it content to the blood. This one now is what leads to embolism. So this one will treat the platelet aggregation and the by what is called the platelet activation factor, and there is the robust formation. At that extent, into the adenomatous plague and the anterior lumen, this one causes partial or complete obstruction at the site of lesion, can cause distal embolization, and from the distal perspective of the blood supply, can cause a result in infection, can also result to also necrosis, and also if it can get a secondary bacterial infection, it can also become gangrenous. So also it can cause ischemic of the affected organs on the distal perspective. So this is an example of a stable angina and stable angina, pectoris, and myocardial infarction where there is stem 1. So you can see in this stable angina, there's adventitia, endothelium, and lumen. You can see the key thing there is about the necrotic center, which is taking place deep inside these blood vessels. Something is peculiar. The chronic tissues they are taking place there in this stable angina. So the lumen is not affected, but it is narrowing. Then there is the atherosclerotic plague, which is projecting inside the lumen of the blood vessel, narrowing and compromising the turbulent blood flow, and also the forces and affecting the osmotic pressure, is affecting the endostatic pressure, the oncotic pressure, all of them, which where the blood flows, and also it interferes with peripheral resistance, which is a key factor in a modification of blood pressure. So in the coronary arteries. So the other one is unstable angina pectoris. This one you can see that the necrotic tissue is becoming big. It is pushing forward and outwards. Then you can see now there is ulcerated fibrous tissues there, and then you can see that now repair started taking places, and there is the position of thrombus, and these thrombus can be blown in a part of the body, causing complete obstruction. You can see that the lumen of this coronary artery is almost completely occluded, and that you can imagine what is happening there. There is no there is no proper blood supply to the distal perspective, and most likely the organ affected has started compensating. So you can see the third one is myocardial infarction. In this one, there is a complete occlusion of this blood vessel. You can see the necrotic cells. This is there is big. The emboli has already occluded the whole blood vessel, and this one is a myocardial infarction. So in this case, now the patient, the organ should be able to compensate by either doing a vascularization, or a doctor can come in and start doing what is called bypass surgery. So let us look at the risk factors of coronary artery diseases. What are the risk factors of coronary artery diseases? There are factors which you can change, and there are factors you cannot change, or we call them absolute risk and relative risk. For example, age, the more you grow older, the more you are at risk of developing coronary arteries. And if you are male, you are at risk of developing coronary arteries. And if there is a positive family history of coronary artery disease, also that is a risk factor. So the other one is there is those relative risk factors. Those ones we call them environmental factors, because you acquire them. You can change them in statistics. They are called modifiable risk factors or variables. For example, smoking, hypertension, and diabetes mellitus, hemostatic factors, physical activities, obesity, alcohol intake, and other dietary factors, personality, and social deprivation. Those are risk factors which you can modify. So age and sex. So in premenopausal women, they have a low risk of diseases than men, because these type of women, they have the reproductive hormone which are taking care of the body, the estrogen, progesterone, you got the RH hormone. All of them are taking care of this and during this period of production, of reproduction. So though the sex differences disappear after the menopause, since and during menopause these hormones disappear. So there is all of them, they are at higher the equal risk of developing coronary artery disease. So if there is a positive family history, if the problem runs in the family, if we have a relative who has a blood relative who has a history of coronary artery disease, it most likely runs in that family because of genetic determinations. So environmental factors and the lifestyle also increase. For example, if you have a genetically pre-exposed, you are also having living in an environment where you have a stress and also lifestyle factors like your obesity. Definitely, there is higher chances of you developing a coronary artery disease in this type of people. So smoking is another big problem. It's a risk factor of causing ischemic heart disease, and it is persistently consistent. And those linked to the relationship between cigarette smoking and ischemic heart disease, especially in young guys who are less than 70 years. So again, if you are smoking and you are having hypertension, you are directly proportional. And if you are smoking and you have high cholesterol, then again, you are also at high risk of developing coronary artery disease. If you are smoking and you are diabetics, also you are at higher risk than anybody else. And men with type 2 diabetes have 2 to 4 times greater high risk of coronary artery disease if they are smoking. And with women who have type 2 diabetes, they have 3 to 5 times risk if they are smokers. So there is other factors like hemostatic factors. That is, if there is a problem in the blood, hematological factors like platelet activation factor, high levels of fibrinogen and phospholipins antibodies, recurrent arterial thrombosis. All these type of problems can lead to coronary artery disease. Physical activities, if they are not active, so that you can burn the fat. As you know that physical activity is recommended where you should be making 2 kilometers walk per day. So regular exercises can increase serum high density cholesterol concentration because high density cholesterol is very important for transport in the body. So exercise again lowers the blood pressure and also assists in the vascularization. That is the development of collateral blood vessels. So again, another risky factor is obesity, which is associated with hypertension and cardiovascular diseases, and also associated with diabetes, because this one interferes with the receptors like beta receptors. The cholesterol displaces these the receptors in the body. So another risk factor is alcohol consumption. Another one is diet. Diet deficiency in like lack of fresh fruit, vegetables, unsaturated fats, acid is very important. So personality, like little or no evidence of there's little or no evidence of population believe that stress is a major cause of coronary artery disease. Obviously, it is far-fetched type of argument because stress causes high production of what? Causes high production of hormones, which causes hypertension, resulting to hypertension, and hypertension can result to coronary artery disease. Other things is like social deprivation, like social lack of social amenities. So let us look at pathogenesis of coronary artery disease. So the underlying pathologies of coronary artery diseases are atherosclerosis, purely the hardening of the blood vessels resulting to narrowing of the lumen. So atherosclerosis, which is hardening of the blood vessels, is so in this case, a patient has risk factors like obesity, results to atherosclerosis. Atherosclerosis results to embolism, and this thrombosis causes to heart attack because there is a complete blood vessel obstruction supplying to the heart, and this is the coronary artery. So the key processes in atherosclerosis is there is intimal thickening and also lipid accumulation resulting to what? To blood vessel occlusion, which in this case we are talking about the coronary artery, which is the key supplier of the blood to the myocardial cells. So these processes will produce the aromatase free, like the one you can see there. That's aromatase free, which is there. So the pathogenesis is there is a atherosclerotic is a chronic inflammatory response of the artery walls initiated by some form of injuries to the endothelium. So if there is any endothelial injuries, the endothelium can be either because of an infection, can be because of a leukocyte initiated type of endothelial injuries, or sometimes even the endothelium can be also because of neovascularization and leakage into the blood vessels, like for example in cancers. All these ones can initiate what is called atherosclerosis, hardening of the blood vessels, hardening of the blood vessel. So that in number one, we can see that there is this one and the position of the endothelium dysfunction because of increased permeability. Leukocytes start adhering, and then monocytes adhering, and then it start migrating from the blood vessel, from the blood flow to the walls. So they start now attacking the walls. In this wall, they start stimulating what we say the intrinsic pathways, because the endothelium is provoked to be produced prostaglandins, the interleukin-1, interleukin-6, tumor necrotin factor, tumor growth factor, and interferon, and also some chemokines are produced, and also sometimes can initiate what is called the prostate activation factors can be provoked, in this case, starting now initiating a process of inflammation and coagulation in this type of patient. So the smooth muscles migration from the medial to the intimal, and this one results to activation of macrophages, and these macrophages now result to start initiating a process of eating, which now makes a deposition of fibrin with fibrinogen, and then now handling of this blood vessel. So The macrophages and the smooth muscles engulf the lipins, lymphocytes come there, so you can treat the fatty streak and also smooth muscles proliferation, collagen, and the ESM and the position and extracellular field. So you can see as the fibrofatty adenoma, how it is taking place slowly. You can see how the collagen is being deposited there, the lipid debris, and because of the injury of the intima, the inner part of his blood vessel on the endothelium. So this is a cross-section of blood vessels. You can see slowly there's a normal section of the artery. There's a artery which has a injury. You can see the fat tissues are getting deposited, and then the rusting. You can see the ribbon is almost completely occluded by the deposition. So most of the patients with coronary artery disease are coronary atherosclerosis, which causes obstruction of the blood flow to the coronary, to the myocardial cells. So the presentation of patients with coronary artery diseases can be so many ways. Some of the patients just live their normal life, which is asymptomatic. They don't manifest any symptoms unless if there's a complete occlusion. Others, they have a chronic stable angina. Others have acute coronary syndrome. Others have acute coronary syndrome, which can be either unstable angina or ST-related myocardial infection or ST-related myocardial infection. Some patients of coronary artery diseases can be diagnosed during a postmortem because they will appear dead of unknown cause. Other manifestation of coronary artery disease is heart failure. Heart failure in this type of patient may manifest with heart failure. It's another manifestation of a coronary artery disease. So in these manifestations of coronary artery disease, in asymptomatic, there is depends with the degree of obstruction, and the higher the degree of obstructions, the higher the symptoms appear. And in the early stage, that is when there is total occlusion of these blood vessels, and that is when this issue of symptoms start coming in. So a patient may also lose their sensation of pain as a result of neuropathy, especially in diabetes mellitus, depending at what part of the body where this blood vessel is affected. And these neuropathies always affect the extremities of the blood of the body, like the lower limbs. So sometimes the patient manifests with a sudden death, and this one first manifests in 25% of the patient, and 20% of the patient with acute myocardial infection will die before reaching to the hospital. And most of these deaths are caused by either ventricular fibrillation. And ventricular fibrillation is there is uncoordinated there's uncoordinated activation of the ventricles, so it is seeking various impulses from various parts of the body, and more common this type of patient can be either aortic or complete bundles broke. So in angina pectoris manifestations of coronary artery disease, angina pectoris purely is not a disease, it's more of a symptoms, which means there is an underlying process in the body like ischemic heart disease. So it describes as a heavy, tight, gripping pain on the chest, on the pericardium, and the patient enters the consultation room and bending forward and complaining of a pain. And the patient is unable to complete a complete sentence. They cannot be able to make a paragraph, and they just speak, putting the wrong full stop in, because they have to stop in between the sentence to breathe. So typically it is centrally and electrosternal, and mild pain to most severe than that provokes sweating and sometimes fear. So it is associated also with breathlessness. So in angina pectoris, there is imbalance of oxygen supply and demand, resulting to anaerobic metabolism, which results to lactic acidosis, causing acidosis in the myocardial cells, which now they start getting sick, they get destroyed, and then they start not functioning well. There is increased blood flow. So the result is there is a chest pain because of buildup of this lactic acidosis. And there is activation of canine, bradykinin, histamine, and other substances released in this case. Sometimes even the kidney itself can also start now provoking the RAS system. RAS system can start now misbehaving in this type of patient, because if the kidney is activated now, and you know that the kidney is produced by the glomerular and apparatus after the macular and denser cells are activated now, this one can now start having a manifestation of kidney or rather endocrine pathways. At this point, it can either, if the canine is affected, it can either go the renal pathway or it can either go the endocrine pathway, depending on the composition or how the body is able to do what is called the coping capacity. So the nerve fibers are stimulated. So paroxysmal and usually recurrent attack of sternocleidomastoid chest discomfort is assisted with angina pectoris, and this chest is described as constricting, squeezing, and choking, and knife-like type of pain. So there is a classification of angina pectoris. There are two schools of thought in terms of classifications of angina pectoris. The first one is Canadian Cardiovascular Society functional classification of angina. This one is classified as per the function. And the first class is the patient is normal, ordinary is active, and the angina will be as angina only with strenuous exercise. If the patient runs, if the patient carries does every activities, at the time the patient manifests with the symptoms. That is class 1. So in class 2 of angina pectoris, in this Canadian Cardiovascular Society classification, there is a slight limitation of ordinary activities, and the third stage is there's marked limitation of ordinary activities, and the fourth one is inability to perform any activities without symptoms. At this point now in stage 4, the patient now is unable to, even at rest, they have a dyspnea even at rest. This type of patient have anemia even at rest. So also we have another classification of angina pectoris, and this one is a classification of angina pectoris depending on the severity. So the severity is that there is class 1, which one is a near onset angina pectoris and no rest pain. So in type 2, in this Bourne classification, which classifies as severity, there is angina at rest in the preceding month, but not past 48 hours. And then stage 3, there is angina at rest in the preceding of 48 hours. So that is Brown classification of angina pectoris. So let us see classical or external exertional angina pectoris. This one is characterized by constricting discomfort in the front of the chest, arms, neck, jaw, and provoked by physical activities, especially like running or sometimes taking a meal, if it's cold, with weather, even anger, or sometimes excitement. It is always relieved within minutes with rest or taking some nitrate drugs, and occasionally it disappears with continued exertion of walking. It is what is called walking through the pain. So in the early stages of excitement, that is the time it appears. But the more you continue and cope up with that excitement, then the pain disappears. So typically the angina has all the 3 features. And the atypical angina has 2 out of the 3 features. And the non-angina chest pain, 1 or less of these features is what is called non-angina chest pain. So this is a typical demonstration of angina pectoris pain. The pain can see that it originates in between at the sternum, at the candidate, the epigastric region, and you can confuse it with either gastritis or peptic ulcer. It can see that it is rotating around the pericardium. You start, and then you can see that It can go to the shoulder, to the neck. It can go to the chin. It can go to the left arm, to the right arm, and also the medial perspective of the left arm. That is how the typical angina pain behaves. And the patient comes to the clinic bending forward. So there is shortness of the breath, nausea and vomiting, weakness, corruption, sometimes coma, and sometimes there's difficulty breathing, like perspiration. So the patient feels like as if the chest is being squeezed from anterior and posterior perspective, or sometimes the patient feels as if the chest is having a crashing with somebody is sitting on the chest, or something is constricting the chest. We'll how it appears. So this type of pain of angina pectoris can also sometimes migrate to various parts of the body. The patient can come with a pain on upper chest. The patient can come with a pain on a substernal. This pain is relating to the neck and jaws of the body. Sometimes the patient can come with the sternal or relating down to the left arm. The pain is on the shoulder, the medial perspective, or sometimes the pain can be at the epigastric and you can confuse it with other conditions. The other one, the pain can be at the gastric, relating to the neck, to the jaw, and also to the bilateral arms. Sometimes the pain can be just on the jaw and the neck only, and sometimes the pain can be what? Can be on the shoulder and down on the arms, and also the pain can be capsular space. And you remember that at that point, that is where the nerve which innervates the diaphragm and other viscerals originated from. So it is very important. So the point is that at this point is that any patient who has diabetes, who has hypertension and present with a chest pain, always you have to think beyond that chest pain. You have to evaluate all causes of chest pain because you can miss some of these diagnoses. So there is various types of angina. There is a stable angina, there is unstable angina, and there is a refractory angina, and there is a variant angina. So the stable angina is episodic clinical syndrome where there is no change in the severity of the attack. The unstable angina is there is introduction within 24 hours in the previous stable angina with the symptoms of frequently occurring at rest. And this one is very common in acute coronary syndrome. So refractory angina is patient is having a severe coronary disease in whom there is revascularization. The body has started now developing other blood vessels to compensate and this type of angina. So there is also variant angina which occurs due to prolongation, are usually at rest as a result of coronary artery spasm and more frequently in women. So in stable angina, characterized by central chest pain, discomfort, or breathlessness that is precipitated by exertion or other forms of stress, and this is promptly relieved by stress. So activities precipitate this type of angina. It is very commonly associated with the physical exertion, sometimes cold exposure, heavy meals, and intense emotion. And commonly, when somebody is lying flat and the cubitus is called the cubitus angina, also sometimes like that one, and also as a vivid dream, when somebody has some funny dream, nocturnal angina can develop that type of angina and nocturnal angina, and because out of the action of the dreams. So the clinical evaluation of angina is that history is far the most important factor in making the diagnosis. You have to interrogate your patient properly. You do physical examination, continue asking patients, be careful searching for evidences like valve diseases, particularly aortic. Either it can be either aortic irritations or it can be aortic stenosis. Left ventricular dysfunctions because of cardiomegaly, it can be associated with gut bleeding. You start thinking of cardiomegaly, or if there is a displacement of the apex beat. So atrial diseases like carotid bleeds, peripheral vascular diseases, also you have to charge for those. So unrelated conditions that may exacerbate angina is like anemia or sometimes thyroid sclerosis. Because this one, there is excessive energy needed and blood in the body. So important assessment of these factors is, for example, hypertension and diabetes. So, what investigations do you do in this type of patient who have a coronary artery disease or rather who have myocardial infarction? So, in this one, you do what is called the arresting ECG. This one may show either the patient had a previous myocardial infarction and the severe of cardiovascular coronary artery disease. Occasionally, the T wave flattens and also inversion in some beans and providing non-specific evidence of myocardial ischemic damage. So the behavior of ECG depends with the division this attack of infection. Infection depends because the more it continues, the more it starts changing in the ECG. So the appearance of ECG should be interpreted together with the progressive of the disease. So you have to ask the patient at what time they get the attack, how many minutes you have to complete, then continue checking so that you know at what point it is, so that you know the behavior is at the time the patient the ECG was taken, does it correspond with the findings of the ECG? So the most convincing evidence of myocardial infarction is the reversible ST segment depression or unabated with or without TV inversion at the time of patient is experiencing symptoms. So exercise ECG also can be done. This is called exercise tolerance test, and this one is done on a treadmill or a bicycle with a monitoring gadget, ECG, and the blood pressure, and this one can generate general conditions. So then you can have frontal downstroke, 60 duration of more than 1 liter is indicated for ischemic heart disease. Also, posting ST depression is very specific and often occurs in normal individuals. This is an example of exercise ECG. This is an example of exercise ECG. You can see the gadgets, the blood pressure is being monitored, and the general physical is getting monitored, and the ECG, the reads are in position on the patient. So another investigation which can be done on patient having these coronary artery diseases, you can do myocardial perfusion scanning, and also you can do what is called a stress echocardiogram. So you can do a stress echocardiogram. So also, you can do coronary arteriography, which is shows the detailed anatomical information about the extent and the nature of the coronary arteries. It indicated when there is non-invasive test as failed to establish the cause of atypical chest pain. So, under local anesthesia is done and requires a specialized radiological equipment like cardiac monitor and experienced cardiothoracic team. So in this photo, you can see there is an aneurysm and there is an aneurysm of coronary arteries. There are 2 aneurysms of coronary artery disease. So you can do, this is what is called the coronary angiography. You can see that the catheter is inserted, and the catheter is always inserted at the inguinal, the femoral region up there. And then there's you can see the how it goes and the inspectors, and you can see that it is seeing that stenosis. So, what is the management of these angina pectoris? The one is a stepwise type of management in this type of patient. So, a stable angina on effort, you test for stress test. If the stress test is negative, then you have to review your diagnosis and start looking for other causes of this problem. You have to think wider. But if the stress test is positive, you modify the lifestyle of this patient. You advise them on lifestyle. Then you also do secondary prevention like diabetes, antihypertensive. If the patient is having hypertensive, you control it, and also if the patient is having diabetes, you control it. Then you can give anti-angina therapy. Those are the nitrate drugs if the test is positive. So if the patient is high risk, you assess for high risk. If it is no, and there is persistent symptoms, If there's persistent symptoms, then the patient is has no medical therapy, then you don't give the medical therapy. But if the patient has persistent symptoms, you do coronary angiography, and the patient is on medical therapy. But if the patient you do coronary angiography, and there is setup for revascularization, then you continue. If you see that the angiography and the coronary arteries can be able to develop other blood vessels on their own, compensate, then you continue the medical therapy. But if it cannot be able to do that one, then you do what is called coronary artery bypass grafting. Coronary artery grafting. So in medical management of these diseases that you give antiplatelets, then in a blood, you give low dose of aspirin, 75 milligrams, if the patient is not contraindicated in aspirin. This one reduces the adverse effect of the disease, such as myocardial infarction, and it is prescribed for all patients with the coronary artery disease indefinitely. So also, you can give clopidogrel if the aspirin is contraindicated. So also you can give anti-angina drugs. There are 5 types of drugs like nitrate, beta blockers, calcium antagonist, potassium channel activators, and IF channel antagonist. The nitrates drugs act directly on vascular smooth muscles to produce venous and arterial dilatation. So these ones, they work on both arterial and the venous. So you have to be very careful because they can cause a transient hypotension. So there is reduction in myocardial oxygen demand and increase in myocardial oxygen supply. Prophylactically, before taking exercise that is enough to provoke symptoms. Continuous nitrate therapy can cause pharmacological tolerance and should be avoided 6 to 8 hours nitrate free. So for you to have the patient to have a tolerance, you have to ensure that the patient have 6 to 8 hours without nitrate drugs free for the purpose of drug. So nocturnal angina, long-acting nitrate can be given at the end of the therapy. So there is various type of presentation like transdermal DNA, oral isobdodamate, and oral isobdomonate. You can see the peak action and the duration of time of action. So the beta blockers lowers myocardial oxygen demand by reducing heart rate, blood pressure, and myocardial contractility. They provoke bronchospasms in patients with asthma, so you have to be very careful. Don't give beta blockers in patients with the hypersensitivity or patients who have conditions like asthma. So you can give calcium antagonist. This one, they inhibit the slow in-one current caused by the entry of the extracellular calcium with the cell membrane of the exciting cells. Particularly, these calcium antagonists, they work on cardiac and artery and smooth muscles. They work on myocardial oxygen demand by reducing blood pressure and myocardial contractility. So the other drug is you give potassium channel activators, and these potassium channel activators, they do artery and venous dilatation properties, but do not exhibit tolerance swing with nitrates. So they have safer drugs. So like an example is called in Coronary, which is to give 10 to 30 milligrams 12 hours orally, and the only drug in this class currently available for clinical use. It's the only Coronary potassium channel registered for use. Other drugs like IFF channel antagonists like Ivandolil is the first of this class of drug. It uses bradycardia. You have to be very careful so that it does not cause bradycardia by inhibiting ions channel in this sinus node. Comparatively, the dose does not have any other cardiovascular effect. The only one is the causes of bradycardia. It is safe to use in patients with heart failure. So it is management is conventional to start therapy with the raw aspirin, 75 milligrams of aspirin, or can give a statin, can give sublingual nitrate, you can give beta blockers. and then and a calcium channel antagonist, or a long-acting nitrate that need be. So GO is the control of angina with the minimal side effects and the simplest possible drug regime. And also in our setup, affordability, accessibility, and availability of the drug is the key for the purpose of subscribing to universal health coverage. Little evidence that prescribing multiple anti-angina drugs is often of benefit, and the revascularization if an appropriate combination of 2 or more drugs used to achieve an acceptable symptoms response. So the other type of management, you can do what is called percutaneous coronary intervention. This one, you pass a fine guide wire across the coronary stenosis under radiological control. Balloon is placed and then included to dilate the stenosis. Then a coronary stent is deployed on the balloon and maximizing and maintaining the dilatation of a stenosis vessels, reducing both acute complications and the incidence of clinical importance. Stenosis. So mainly used in single or 2 blunt vessels on the coronary. So that is an example of how it is done. There's you can see how the wire mesh, how it is done there. The ultimately dilate the blunt vessel, the coronary artery. Then we have what is called the coronary artery bypass and grafting. So in this case, the stenosis artery is bypassed with the internal mammary artery. Then internal mammary artery is harvested, or radio artery is harvested. Then a reverse segment of the patient own saphenous vein, also even saphenous vein can be harvested. And major surgeries and the pulmonary bypass, but in some cases, graft can be applied to the beating heart, or sometimes off pump surgery. So operative mortality is approximately 1.5%, but risks are higher in elderly patients with poor left ventricular functions, and patients with significant comorbidities, just as renal failure. So 90% of patients are free of angina first year after coronary artery bypass grafting. But here, 60% of patients are asymptomatic after 5 years or more. So that is an example of coronary artery bypass. You can see the bypass being done. You can see the internal mammary artery bypass done. After that, blood vessel was harvested there to bypass that blocked artery. You can see the saphenous vein bypass done on this patient. So let us look at what is called acute coronary syndrome. It consists of myocardial infarction, where the ST elevation myocardial infarction stem on ST elevation myocardial infarction. Symptoms occur at rest. Evidence of myocardial necrosis increases cardiac troponin or creatinine, against MB isomer. Unstable angina, new onset rapidly worsening angina, or that is crescendo angina, angina on minimal exertion, or angina at rest in the absence of myocardial damage. So it presents as a new phenomena or against a background of chronic stable angina. Complex, accelerated, or feature agglomerata spring with a direct paratrate, each thrombus, and local coronary arteries spasm. Dynamic process is the degree of obstruction may either increase or regress. Without treatment, the impact-related artery means permanently occluded for 20 to 30% of the patient with this acute coronary syndrome. The point here is that you can see that a patient can have a chronic stable angina or a chronic coronary syndrome, and yet can develop acute coronary syndrome in it. So the universal definition of myocardial infarction, it's evidence of myocardial necrosis in a clinical setting consistent with myocardial ischemia, in which case any of the following meets the diagnosis of myocardial infection: detection of breast or stroke, 4 of cardiac biomarkers, preferably troponin, ECG change indicative of new ischemia, that's new ST, T changes or new left bundles and black block. Development of pathological QAs, imaging evidence of new loss of variable myocardial or new regional or motion abnormalities. So what are the clinical features of acute coronary syndrome? So the symptoms is that there is a cardiac cardinal symptoms of pain, prolonged cardiac pain, chest drum, throat pain, arm, and epigastric or back. There is anxiety and a fear of impending death, nausea and vomiting, breathlessness, and collapse, and sometimes syncope. So the clinical features of acute coronary syndrome is that the patient may have asympathetic activations like pain, sweating, and tachycardia. There is vagal activation like vomiting, bradycardia, sense of impaired myocardial functions, hypotension, polyuria, cold peripheries, narrow pulse pressure, listing GVC, jugular venous pressure, then heart sounds, and quaint fast heart sounds, diffuse epical impulses, and lung repetitions. Tissue damage, which can be associated with signs of fever. Complications is like mitral regurgitations and pericarditis. So the investigations in acute coronary syndrome is that you do electrocardiogram, which confirms the diagnosis. So in this case, the ST segment is dilated, ST segment is elevated, and the T wave inversion change in the ventricular repolarization. There is persistent after the ST segment has returned to normal. Reliable for the approximate age of the impact to be deducted. So it is very important when you are doing the ECG to take a proper history of the patient so that you know at what point are you in this infarction, because the ECG appearance changes with time. Like for example, before infarction, that is the normal ECG. Few minutes after that one, you can see the ST is elevated. Then 1 hour, the Q wave is just down. Then the Q wave is down, and then the coronary T is widening, and then you can see that months the Q wave is down. And that is how it appears. That's A is the normal ECG complex, B is the acute ST elevated in the coronary injuries, C is the progressive loss of R wave and developing of Q wave resolution of ST elevation and terminal T wave version. D is deep Q wave and T wave inversion, and E is own or established infarction pattern. So what type of investigations do you do in acute coronary syndrome? There is an ST segment elevation in acute coronary syndrome. There is partial occlusion of major blood vessels or complete occlusion of minor blood vessels, and stiff angina or partial thickening due to some endocardial and myocardial infarction. ST segment depolarization and T wave changes. Presence of infarction, cause of R wave in the absence of Q wave. So that is how it happens. This arterial and ST elevation in some endocardial myocardial infarction. There is a deep symmetrical T wave inversion together with a reduction in the height of R wave. This is an example of acute coronary syndrome types of waves. So what type of investigation you do? Plasma cardiac markers like creatinine kinase, isomer or enzymes, specifically proteins like troponins T and I. And also you can check on the presence of skeletal muscles. Also they are present but not SK, which is the only present in cardiac muscles. And the differential diagnosis is intravascular injections, vigorous physical exercise, and particularly in old people and the people who are fallen down. So that is how the appearance of these enzymes with the onset of acute coronary syndrome. So again, when you're interpreting this test, you should understand and you should be able to know the history of the patient so that you know at what point you are dealing with this type of coronary artery acute coronary syndrome. So investigations is cardiac enzymes. You can do globulin, troponin, creatinine kinase, or ALT, lactate, and the androgenase. Other blood tests, I can do ESR, you can do C protein, C reactive proteins, you can do chest X-ray, and also you can do echocardiogram, which can tell you neurothrombus, cardiac rupture, ventricular septal defect, mitral regurgitations, and sometimes pericardial effusion. So the management of acute coronary syndrome is that you admit the patient to the hospital as quickly as possible and reduce the incidence by 60%. You give oxygen by nose, and also you take history immediately and monitor the factors like diabetes, hypertension, renal diseases, intravenous access. You establish an intravenous access, you take blood for markers, you do ECG, and then aim at early management by controlling the giving analgesic thrombotropium. You prevent the embolism by the thrombotic, and then you give anti-angina therapy, and then you do perfusion therapy of the patient. So the management you give sublingual glycerin nitrate, 300 milligrams, 500 milligrams micrograms, fast initial. You give IV nitrate, GNT 0.6 to 1.2 milligrams hourly, or you give isobidol 1 to 2 milligrams hourly. Left ventricular failure and the relief of recurrent or persistent ischemic pain can happen. Those are the treatment give. Then you can give intravenous beta blockers like atenolol, metoprolol, or over 5 minutes, which can relieve pain and reduce arrhythmias and improve short-term mortality in this type of patient. Never give IV beta blockers if the patient is having a pulmonary edema due to heart failure, hypertension, or blood pressure of systolic of less than 105 and bradycardia of less than 65. So the hydroprenyl calcium channel blockers, antagonists like Andrat and Broadband can also be handled to the beta blockers with the persistent chest discomfort continues, but may cause unwanted tachycardia in glucagon, and because of their rate of limiting action, verapamil and indretazine are the calcium channel blockers antagonists for choice if a beta blocker is contraindicated. So you give analgesics like opiates, you can give also antiemetics like metoclopramide 10 milligrams, or also you can give them intramuscular to avoid small skeletal muscles perfusion and painful hematoma. So you can give antithrombotic therapy, like you can give aspirin, the low doses of aspirin, but you start with the loading dose of 300 milligrams, and then for the fast within the 12 hours, then followed by 75 milligrams. And it's very good for you to give a content type of aspirin. Again, you can do dual therapy of aspirin plus clopidogrel, 600 milligrams, hardy within 12 hours, followed by 150 milligrams daily for 1 week, and 75 milligrams thereafter. Or you can give ticagrelor, 1 milligram followed by 90 milligrams 12 hourly, more effective than clopidogrel. This one is more effective. So also you can give antiplatelet treatment with IV glycoprotein, 2B or 3 inhibitors, which reduces the combined endpoint of death of myocardial infarctions, and used in context of PCI. Examples are ambexman, trobriman, and eptizambe. So you can give anticoagulant, which reduces the risk of thromboembolic complications. You can give fractionated heparin, or pentasaccharide, and you continue for 8 days until discharge from the hospital, or coronary revascularization has taken place. So the other treatment, you can do what is called perfusion therapy, depending on the type of myocardial infections. Outcome of the perfusion therapy varies with either it is non-stem, non-demonstrative benefit, or stem, which restores coronary artery patency and preserves left ventricular functions and improves survival. Medium to high risk patients do not benefit, but this does not need to take place in the past 12 hours. Primary percutaneous coronary intervention is very important in perfusion therapy. You can do thrombolysis. Thrombolysis reduces hospital mortality by 25 to 50%, and this survival antibiotic is maintained for at least 10 years. So at the piece, human tissue plasminogen activator over 90 minutes, Moras dose of 15 milligrams, followed by 0.75 milligrams per kg body weight, but you should not exceed 50 milligrams over 30 minutes. Then for 0.5 milligrams per kg body weight, but does not exceed that 5 milligrams over 60 minutes. Better survival rate than other thromboembolic agents, just as streptokinase. Analogs of TPN is tenecteplase and ectipase, and a long plasma half-life than ectipase, and can be given as intravenous bolus. So the treatment again is you check on risk factors. You advise the patient to stop smoking, regular exercises, weight control, and lipid lowering product. Then the secondary prevention in drugs is like antiplatelets, beta blockers, AC inhibitors, statins, and additional therapy for coronary of control of diabetes and hypertension. You can also give androstenedione receptors antagonists. Rehabilitations like implantable cardiac defibrillators also can be given. So assessing aggressive risk factors modifications like blood pressure, diabetic control, weight management, and lipid is very important. In this type of lipid management, you have to ensure that low density lipids is less than 2 millimoles per liter. And you can also add azitamine, which is a drug which prevents absorption of lipids in the body. So you give PCSK9. This one is preserved for the management of familial hypocholestemia, where the hypocholestemia is genetically determined. This is the safe drug to use. So again, you give antiplatelets. In this type of patient. So complications of acute coronary syndrome is things like arrhythmias, ischemia, acute coronary circulatory failure, pericarditis, mechanical complications like rupture of the papillary muscles, which now can result to regurgitations, rupture of the interventricular septum, rupture of the ventricles, embolism, or sometimes impaired ventricular function, remodeling, and ventricular aneurysm. So this is the chromosomal management of these type of conditions. As we have discussed there, how would you approach this type of condition? So the primary prevention is strategies taken before onset of the disease in high risk individuals. Populations strategies is like you educate the public awareness is very important, restriction of smoking. Then you can also focus on targeted individuals and groups in this prevention. So secondary prevention is like you give this smoking, hypertension, you assess these things, then you deal with hypercholesteremia, you give a statin, aspirin, and beta blockers. They give beta blockers to prevent myocardial infarction or heart failure. And that is the end of this lecture on the ischemic heart disease.